Every day you choose to move, your body responds with strength, balance, and renewed life. Each gentle motion is a gift to yourself, calm, mindful, and full of vitality. Together we move, we heal, and we thrive. Keep the rhythm of your golden years. Nurture health, cherish every movement. As the global population grows older, maintaining independence and quality of life has become a central concern for individuals, families, and healthcare systems. One of the most powerful tools science has confirmed for slowing age-related decline is movement, but not just any movement. Regular practice of a few core evidence-based exercises can dramatically enhance balance, strength, and coordination, helping adults over 60 continue to live safely and confidently on their own. This video focuses on 3 essential exercises that no older adult should skip: the chair-assisted squat, the glute bridge, and the side plank. Each targets a major area that weakens with age: leg strength, core and spinal stability, and side-to-side balance. When practiced consistently with proper form and gradual progression, they can improve walking, reduce pain, prevent falls, and restore functional confidence in daily life. You don't need a gym, expensive equipment, or long sessions. Just 15 to 20 minutes 3 times a week can make a remarkable difference. If you find this guide helpful, please give it a like, share it with your loved ones, and subscribe to stay updated with more simple, science-backed routines for healthy aging. Continue watching the next videos in this playlist to build a stronger, more mobile, and independent version of yourself, one small step at a time. Exercise 1. The chair-assisted squat, the cornerstone of functional autonomy. The significance of the sit-to-stand transition. Ascending from a seated posture is one of the most essential human actions. The sit-to-stand STS transfer, clinically recognized, is essential for activities including rising from bed, standing from a dining chair, utilizing the restroom, and entering or departing a vehicle. Due to its prevalence and functional significance, the STS movement is frequently employed as an objective evaluation in clinical practice. The STS test, often quantified by the number of complete stands executed within a predetermined duration, usually 30 seconds, or the time required to accomplish 5 repeats, functions as a validated indicator of lower body strength, dynamic balance, fall risk, and overall mortality among older persons. Decreases in STS capacity often precede observable declines in mobility and independence. Conversely, enhancements in STS performance are associated with improved functionality and decreased healthcare utilization. The chair-assisted squat is a targeted and intentional training method for the sit-to-stand movement. In contrast to non-specific leg exercises, the chair squat practices the exact neuromuscular pattern utilized in daily transfers, activating the primary muscle groups and motor control methods necessary to elevate the body against gravity and restore stable upright posture. The chair squat, through incremental adaptation, mitigates sarcopenia, reinstates lower limb strength, and enhances the coordination required for secure transfers. Biomechanical relevance and muscular activation. The chair-assisted squat is a compound, closed kinetic chain exercise that engages multiple major and mechanically significant muscles of the body. Quadriceps. Serving as the principal knee extensors, the quadriceps produce the majority of the force necessary during the ascent phase to extend the knees and elevate the body vertically. Clinical data associates quadriceps weakness with challenges in stair negotiation, reduced walking speed, and an increased risk of falls. Gluteus maximus. The primary hip extensor significantly aids in hip extension during the ascending phase, stabilizes the pelvis, and facilitates an erect trunk position. Proper gluteal strength is essential for stable walking and effective sit-to-stand transitions. Hamstrings. These muscles facilitate hip extension and function eccentrically throughout the descent to regulate the lowering phase, offering a braking mechanism that improves safety and joint protection. Core stabilizers. The deep trunk muscles comprising the transverse abdominis, multifidus pelvic floor, and erector spinae co-contract to sustain a neutral spine, facilitate force transfer between the lower and upper bodies, and maintain postural stability during movement. Ankle plantar flexors and dorsiflexors. While less apparent, the gastrocnemius and anterior tibialis play a role in balance and the precise adjustments of center of pressure required during forward weight shifts and stabilization in standing posture. When considered comprehensively, the chair-assisted squat transcends a mere leg exercise, functioning instead as a practical rehearsal that amalgamates strength coordination and balance into a singular pattern. It develops not only muscular strength, but also timing, sequencing, and proprioceptive feedback, which collectively provide safe and successful movement. Foundation of evidence and clinical significance. A substantial body of literature associates STS capacity with significant health outcomes. The STS test is extensively utilized as a prognostic indicator of functional deterioration, disability, and mortality risk in elderly populations. Interventions that enhance the targeted muscle groups and movement patterns associated with sit-to-stand transfers have shown clinically significant advancements in mobility and fall prevention. Randomized and quasi-experimental experiments using chair squat training have shown enhanced lower limb strength, reduced sit-to-stand times, and improved balance measures. Community-based programs incorporating repeated STS training over 8 to 12 weeks demonstrated a decrease in fall incidence and enhancements in mobility scores. The mechanisms underlying these effects are multifaceted. Augmented muscular strength improves the ability to rectify perturbations, enhanced dynamic balance diminishes instability during transitions, and increased confidence in physical capability mitigates cautious gait and avoidance behaviors that paradoxically elevate fall risk. Crucially, preserving STS capability disrupts a detrimental feedback cycle. When rising from a chair becomes challenging, individuals often decrease their activity to evade discomfort or humiliation. This inactivity hastens disuse atrophy, further diminishing function and heightening dependency. Consistent chair squat exercise mitigates and frequently reverses these alterations by enhancing task-specific strength and motor control. Methodology, coding, and advancement. Meticulous technique maximizes advantages and reduces harm risk. This instruction delineates setup execution and advanced tactics suitable for a diverse variety of abilities. Configuration. 1. Select a robust, non-slip chair devoid of wheels. Dining chairs featuring a robust base and a seat height that facilitates an approximate 90-degree angle at the knees while seated are optimal. Refrain from using excessively soft or unsteady chairs. For patients with hip or knee limitations, an elevated seat may initially alleviate joint stress. 2. Foot positioning. Position feet approximately shoulder-width apart with toes angled slightly outward if it seems more comfortable. The feet must be positioned to ensure that a forward weight shift aligns them beneath the center of mass, typically somewhat posterior to the knees, while seated. Conduct small anterior-posterior adjustments to identify a comfortable foot positioning that facilitates a seamless forward transition. 3. Posture. Position yourself near the front portion of the seat to minimize the mechanical restriction imposed by the chair back. Preserve a neutral spinal alignment. Refrain from adopting a rounded thoracic posture that restricts hip hinging. An erect torso and mild anterior pelvic tilt can enhance hip activation. 4. Arm placement. Cross arms over the chest or extend them anteriorly. Commence with arms crossed to guarantee that the lower extremities generate the predominant force. Extending the arms forward can enhance balance without significantly diminishing effort. Nevertheless, refrain from pressing hands against the thighs unless deliberately employing it as a regression for aid. Implementation. 1. Commencement. Prior to standing, execute a little forward lean by positioning the shoulders above the feet. This forward motion diminishes the torque needed at the knees. Envision shifting the nose over the toes to promote forward displacement of the center of mass. 2. Ascent. Exhale, engage the heels, extend the knees and hips synchronously, and achieve an upright position. Highlight a robust hip extension by vigorously contracting the gluteal muscles at the apex of the exercise. Maintain an elevated chest and prevent excessive trunk extension that could lead to hyperextension of the lumbar spine. 3. Descent. Inhale and flex at the hips while lowering yourself back to the chair, regulating the eccentric descent. Strive for a delicate contact with the seat instead than descending heavily onto the chair. Maintain muscular tension during the last degrees of descent to ensure control. Suggested prescription. Novices commence with 2 sets of 8 to 10 repetitions 3 times weekly, allowing 60 and 90 seconds of rest between sets. Emphasize the quality and safety of transportation over quantity. Should tiredness or dyspnea manifest, decrease repetitions or incorporate extended rest periods. Intermediate advance to 3 sets of 10 to 15 repetitions or increase the frequency to 4 times per week if feasible. Integrate tempo variations, e.g., reduce descents to enhance time under tension without augmenting load. Advanced incorporate external resistance or unilateral modifications for increased intensity, such as holding a weight at the chest, executing single-leg stands, or intentionally descending to a lower seat. Alterations and incremental enhancement. For those with significant frailty or concomitant conditions, hand-assisted variation. Provide minimal support from the hands on the chair or thighs, gradually reducing help over several weeks. Initially, position the hands on the knees, subsequently transition them to the hips, and finally remove them. Elevated seat. Execute stands from an elevated surface to diminish excursion and demand. Progressively decrease seat height as strength improves. Partial stands. Execute mini-stands, elevating only to the midpoint to condition segments of the range prior to advancing to complete stands. Gradual negatives. If concentric strength is constrained, concentrate on a controlled descent from standing to sat over 4-6 seconds to enhance eccentric control, then rise with assistance. To facilitate advancement and enhance difficulty, unassisted arms crossed variation, eliminate upper limb support to focus on lower body strength. Tempo manipulation. Extend the eccentric descent phase to 3 to 4 seconds to enhance time under strain and control. Alternatively, employ explosive concentric phases, rapid ascent to develop power once it is safe to do so. Interruption of repetitions. Halt at the midpoint or before to seat contact to enhance control at the extremities. Unilateral exercises. Advance to single-leg or step-up variations when suitable. Assisted single-leg stands grasping a rail may serve as an intermediate stage. Weighted stands. Maintain a light load at the chest, e.g., a tiny dumbbell or household item to enhance resistance while preserving functional patterns. Environmental challenge. Engage in exercises utilizing diverse seat heights and various chair sorts to enhance adaptability. Progress monitoring and safety recommendations. Monitor STS measures, e.g., duration for 5 rises or count of rises within 30 seconds every 4 to 6 weeks to assess enhancement. Utilize basic logs or smartphone timers to record perceived exertion and any discomfort. Cease the workout immediately if discomfort arises, particularly severe or radiating pain, and obtain a professional evaluation. For those with knee osteoarthritis, modify depth and velocity to reduce discomfort and consider joint-friendly progressions, such partial stands, while emphasizing hip-dominant cues. Individuals with balance deficiencies may initially execute the maneuver while utilizing their hands on a steady surface until sufficient control is attained. Exercise 2. The glute bridge, strengthening the core and safeguarding the spine. Rationale for targeting the posterior chain. Chronic lower back pain is one of the most common musculoskeletal disorders throughout life, with its prevalence often rising with age. Chronic low back pains hinder ambulation, standing, domestic activities, and sleep, hence reducing overall quality of life. A common factor in non-specific low back discomfort is the weakening or inadequate activation of the posterior kinetic chain, especially underactive gluteal muscles, coupled with insufficient deep core stability. These impairments modify movement patterns, resulting in compensatory overuse of the lumbar extensors and hamstrings, hence increasing mechanical pressure on the lumbar spine. The glute bridge is a practical low-impact exercise executed in a supine position that primarily engages the gluteus maximus and the synergistic function of deep trunk stabilizers. It isolates hip extension in a comparatively secure position, rendering it optimal for neuromuscular retraining of the posterior chain without considerable spinal strain. Biomechanics and muscular activation. A sedentary lifestyle and age-related neuromuscular alterations might lead to gluteal amnesia, characterized by delayed activation of the gluteal muscles when required. When the gluteal muscles are not activated during hip extension, other muscles, particularly the hamstrings and lumbar erectors, compensate, thereby elevating shear and compressive stresses on the lumbar spine. The glute bridge specifically engages hip extension mechanics and encourages co-contraction of the gluteal and deep abdominal muscles, enhancing pelvic stability and alleviating lumbar strain. Principal muscles highlighted: gluteus maximus, principal muscle for hip extension. Fortifying it reduces lumbar strain during extension activities and facilitates ambulation and stair ascent. The transverse abdominis and multifidus are deep trunk stabilizers that function as an internal corset, reinforcing the lumbar spine and enhancing pelvic alignment during force transmission. Hamstrings function as synergists, aiding the gluteal muscles and facilitating regulated hip extension. Pelvic floor musculature. Frequently activated discretely, these muscles contribute to pelvic stability and enhance core integrity. The bridge enhances glute activation and posterior chain deep core synchronization, fostering healthy movement patterns and potentially alleviating chronic low back pain and dysfunction. Clinical evidence and empirical results. Intervention studies and rehabilitation research substantiate the efficacy of posterior chain and core strengthening for individuals with low back pain. Programs that include glute bridges, in conjunction with other stability and mobility exercises, have demonstrated decreases in pain, intensity, improvements in disability scores, and enhancements in core endurance and functional performance, following very brief training durations, about 4-12 weeks. These results are believed to stem from enhanced muscle strength and refined motor control alterations that immediately impact daily activities and alleviate excessive strain on spinal tissues. A well-conditioned posterior chain enhances balance and mobility by acting as the pivotal component in the kinetic chain. Enhanced trunk endurance facilitates an erect posture during extended standing and dynamic activities, hence diminishing fatigue-induced postural failure and the concomitant risk of trips or falls. Methods and advanced alternatives. Correct technique guarantees that the gluteal muscles assume the principal load instead of the lumbar spine. Configuration 1. Position. Recline supinely on a solid, comfortable surface such as a mat or carpet. 2. Position the knees by bending them and place the feet flat on the floor, approximately hip-width apart. The heels should be positioned such that the fingertips may make contact with them when the arms are fully extended downward. Minor alterations in foot positioning influence hamstring engagement. Narrower stance accentuates glute activation, while a wider stance enhances hamstring participation. 3. Arm positioning. Place hands at the sides with palms facing downward for stability. 4. Spinal neutrality. Initiate with a neutral lumbar curvature not compressed against the floor nor unduly arched. A slight posterior pelvic tilt prior to lifting facilitates the engagement of the gluteal muscles over the lumbar extensors. Implementation. 1. Commence. Inhale to ready yourself. During the exhalation, exert pressure through the heels and elevate the hips by activating the gluteal muscles and engaging the lower abdominal muscles. Envision elevating the hips towards the ceiling instead than excessively arching the lower back. 2. Optimal position. Elevate until a linear alignment is achieved from shoulders to knees. Refrain from hyperextending the lumbar region. Concentrate on commencing movement from the hips. 3. Maintain and descend. Contract the gluteal muscles for 2 to 3 seconds at the apex, then inhale and gradually lower the pelvis in a controlled manner. Preserve core tension during the movement to avert an anterior pelvic tilt at the apex. Suggested programs: novices, 2 to 3 sets of 10-12 repetitions thrice weekly. Prioritize the quality of glute contractions and spinal neutrality rather than focusing on large repetition counts. Intermediate: augment to 3 to 4 sets or extend peak holds to 5 to 10 seconds to enhance isometric endurance and refine neuromuscular control. Advanced: incorporate single-leg bridges, resistance bands, or weights to enhance difficulty and specificity. Alterations and advancements to mitigate range limitations or discomfort. Partial bridge. Elevate a few inches while deliberately engaging the gluteal muscles. Brief peak holds. Initiate with 1-2 second durations and escalate as feasible. Isometric squeezes. Maintain slight contractions with minimal movement to re-establish activation patterns. To augment difficulty, marching bridge. With hips raised, alternately lift one foot slightly off the ground. Preserve pelvic alignment to enhance unilateral stability. Single leg bridge. Extend one leg while executing the bridge on the contralateral limb. This significantly enhances load and augments unilateral strength and balance. Banded bridge position, a resistance band above the knees, and exert outward pressure throughout the lift to target the gluteus medius and lateral hip stabilizers. This mitigates valgus knee inclinations and fortifies hip abductors. Weighted bridge position. A little weight above the pelvis, or position a light barbell across the hips for enhanced strength training suitable when conducted under professional supervision. Tempo variation, decelerate the concentric phase, or execute explosive hip extension when appropriate to enhance power for functional activities such as rapid standing. Incorporation of functional training. Connect bridges to functional activities by training transitions from supine to standing, or by combining with standing hip extension exercises. This approach enhances the transfer of skills to real-life movement patterns and guarantees that improvements in supine strength are applicable to upright activity. For instance, adhere to a series of bridges accompanied by a succession of minor step-ups or retrograde ambulation to stimulate hip extension when standing. Safety guidelines and prevalent mistakes. Typical compensations encompass pronounced lumbar extension arching and hamstring dominance, seen as posterior thigh tightness rather than gluteal activation. To prevent these issues, instruct the learner to slightly tuck the pelvis and concentrate on squeezing the gluteal muscles instead of engaging the hamstrings. If low back pain intensifies during exercise, decrease the range of motion and visit a clinician. If the pain is mechanical and acute, cease activity and seek assessment. Individuals with a history of sacroiliac joint pain should reduce asymmetric loads and prioritize neutral pelvic control. Exercise 3. The side plank, ensuring lateral stability to avert falls. The significance of lateral stability. In older adults, falls are often triggered by lateral or rotational disturbances, such as unexpectedly stepping off a curb, rotating, reaching sideways, or navigating uneven surfaces. Lateral stability. The ability to regulate the body in the frontal plane is an essential yet often overlooked aspect of balance training. Deficiencies in frontal plane strength and endurance heighten susceptibility to lateral falls, which frequently affect the hip and significantly contribute to hip fractures, along with their related morbidity, death, and loss of autonomy. The side plank is an isometric exercise that specifically engages the muscles responsible for lateral stability. Although several core exercises focus on sagittal plane control, front to back, the side plank targets the frontal plane and fortifies the musculature that sustains pelvic and trunk alignment against lateral stresses. Biomechanics and muscular activation. Maintaining a side plank necessitates counteracting gravitational tension at the hips and torso in a lateral position with a synchronized engagement of trunk, hip, and shoulder musculature, obliques internal and external. These lateral abdominal muscles counteract lateral flexion and regulate rotational forces, so supporting the trunk against gravitational descent. Gluteus medius and minimus. Situated on the lateral aspect of the hip, these muscles serve as the principal hip abductors and pelvic stabilizers. They inhibit contralateral pelvic descent during single-leg gait phases and are significantly activated on the bottom leg side in a side plank to preserve hip alignment. Quadratus lumborum QL. A deeper lateral spinal muscle that resists lateral flexion and enhances lumbar stability in the frontal plane. Shoulder stabilizers. The rotator cuff muscles and deltoids engage isometrically to preserve shoulder integrity during the hold. Fortifying these lateral chain components improves the capacity to implement corrective actions when the center of mass is disturbed, hence diminishing the probability that a controllable imbalance escalates into a fall. Evidence and operational results. Studies in exercise science consistently demonstrate that isometric core training, such as side planks, enhances trunk muscle endurance and functional stability. Enhanced postural endurance enables individuals to sustain stabilizing contractions for extended periods during everyday activities such as carrying groceries, standing in line, navigating crowds, or traversing uneven surfaces, thereby increasing the margin between disturbance and failure. Sideways falls often affect the greater trochanter of the femur. Thus, reinforcing lateral stabilizers like the gluteus medius directly enhances hip protection. Programs incorporating lateral stability exercises frequently demonstrate enhancements in balance assessments, less asymmetry in gait, and perceived increases in confidence during mobility activities. The benefits received from side planks when combined with hip abductor training may indirectly decrease the occurrence of hip fractures by enhancing neuromuscular control. Methodology advancement and modifications. The side plank is naturally adjustable and suitable for various abilities and clinical circumstances. Configuration 1. Assume a lateral position on a stable surface or mat. 2. Support. Position the elbow precisely behind the shoulder with the forearm resting on the floor, or for a more advanced variation, place the hand flat on the floor with the arm fully extended. 3. Leg alignment. Position the feet directly atop one another while maintaining straight legs. For a regression, flex the knees such that the lower leg serves as the base and the upper leg is positioned onto it. 4. Whole body alignment. Sustain a linear orientation from the head through the pelvis to the feet or knees in the modified variant. Activate the core to avert hip sagging. Implementation 1. Elevate. Activate the obliques and hip abductors, applying pressure via the forearm and lateral foot to raise the hips until the body aligns in a straight line. Avoid sagging at the hips or slumping at the shoulder. 2. Maintain. Preserve the posture while breathing consistently and ensuring the neck remains aligned. Strive to engage in diaphragmatic breathing to prevent tension in the upper chest. 3. Descend with control and alternate sides to ensure bilateral exercise. Maintain balanced sets, either equal repetitions on each side or somewhat increased duration on the weaker side if asymmetry exists. Prescribed medication. Beginners. Begin with holds of 10-20 seconds per side for 2 to 3 sets, emphasizing precise alignment. Commence with knee-supported grips if necessary to minimize the lever arm. Intermediate advance to 3 sets of 30 to 45-second holds each side as endurance enhances. Advance perform for 60 seconds or more on each side using dynamic features such as leg lifts, rotations, or quick pulses. Regressions and variations. To diminish demand, knee-supported side plank. Flex the knees and elevate from the knees to decrease the lever arm and the load on the shoulder and hip. Wall or elevated surface-assisted side plank. Position the forearm against a wall while leaning laterally, or execute the plank with hands on an elevated surface, e.g. low table, to reduce resistance while engaging the same muscle pattern. Partial range execute holds with a limited lift if full elevation is not feasible. To augment difficulty, full arm side plank. Extend the supporting arm to augment shoulder engagement and incorporate diverse muscle recruitment patterns. Leg lifts. In the side plank position, elevate the superior leg to enhance gluteus medius engagement and test pelvic stability. Dynamic rotations, or thread the needle. Implement regulated rotation to enhance proprioception and dynamic control. Extend the upper arm beneath the torso and retract. Weighted variations maintain a modest weight on the upper hip or ankle to augment the moment exerted on the lateral chain. Unstable surface, execute the plank with feet positioned on a foam pad or bosseau to enhance proprioceptive difficulty only after establishing fundamental strength. Frequent methodological shortcomings. Common faults encompass pelvic descent, anterior torso rotation, and inadequate shoulder alignment. Instructions like stack your hips, press through the elbow, and elevate the ribcage toward the ceiling can enhance alignment. Ensure the supporting shoulder is neither elevated nor internally rotated. Activate the scapular stabilizers to safeguard the joint. In the event of shoulder pain, revert to knee-supported or wall variations and assess shoulder mechanics. Incorporating the side plank into equilibrium training. Integrate side planks with functional balance exercises, such as narrow base walking, tandem stance, or reactive stepping, to enhance the application of enhanced lateral stability in dynamic activities. Employ unilateral standing exercises, single leg stances, with reach to enhance ankle and hip strategies in conjunction with core endurance. Advance to practical exercises such as lateral stepping with reach and multi-directional perturbation training to enhance real-world resilience. Safety precautions and expert advice. Prior to commencing any new fitness regimen, particularly for persons with pre-existing medical issues such as osteoporosis, symptomatic cardiovascular disease, uncontrolled hypertension, severe osteoarthritis, or a history of falls, obtain a medical assessment. A physician or certified physical therapist can evaluate medical risk, identify particular impairments, e.g. vestibular deficits, peripheral neuropathy, and customize workouts to individual functional capabilities. Experts deliver practical guidance to guarantee proper technique, recommend suitable regressions or progressions, and establish safe load and volume to optimize stimulus and recuperation. Indicators necessitating alteration or termination include the emergence or exacerbation of chest pain, acute dyspnea, dizziness, acute or radiating pain during movement, or any neurological manifestations such as abrupt weakness, numbness, or loss of equilibrium beyond anticipated challenges. Individuals with severe osteoporosis or considerable spine degeneration should refrain from excessive ranges or high-impact activities. Instead, they should focus on supervised, regulated, low-impact strengthening exercises. Individuals who have experienced recent cardiac episodes should adhere to cardiac rehabilitation protocols concerning exertion limits and monitoring. Compliance, behavioral modification, and pragmatic execution. Enduring advantage necessitates regular practice. Senior individuals frequently encounter obstacles such as fear of harm, restricted mobility, discomfort, accessibility issues, and motivational difficulties. Strategies to enhance compliance encompass simplicity. A concise regimen of 3 carefully selected workouts can diminish perceived effort and enhance participation. Time efficiency. The outlined trinity can be accomplished in roughly 15 to 20 minutes 3 times weekly, an attainable obligation for several individuals. Brief daily micro-sessions lasting 10 minutes may also be efficacious for habit building. Habit stacking. Associate exercise sessions with established daily behaviors, e.g. post-morning medicine or pre-showering to cultivate enduring habits. Establishing a regular trigger enhances consistency. Progress monitoring. Assess enhancement using objective metrics. STS test lengths hold times, repetition counts to deliver affirmative reinforcement and sustain motivation. Document subjective assessments of task facilitation and perceived confidence in balancing. Social support participation in group classes. Partner sessions or caregiver participation enhances accountability and enjoyment. Peer-led initiatives have shown superior long-term adherence in community environments. Tailoring adjust workouts to accommodate personal preferences and constraints, perceived significance to valued activities, e.g., the ability to rise from a preferred chair, enhances adherence. Incorporate diversity throughout the program to alleviate monotony while preserving essential specificity. Education. Elucidate the functional basis for each exercise and its correlation to daily activities. Comprehending the rationale enhances the propensity to persevere. Pragmatic weekly illustration and advancement strategy. This template is appropriate for a generally healthy older adult initiating a home-based program. Modify amount and intensity according to personal tolerance and professional advice. Weekly schedule 3 non-consecutive days each week. Warm-up 5 to 10 minutes. Mild marching in place. Ankle rotations, hip rotations, shoulder rolls, and light dynamic exercises to enhance circulation and joint flexibility. Incorporate succinct balance exercises, such as single leg taps or deliberate weight adjustments. Circuit for strength and stability. Chair-assisted squats, 2 sets of 8 to 10 repetitions. Concentrate on anterior weight transfer, heel pressure, and glute activation. Glute bridges, 2 sets of 10 to 12 repetitions, incorporating a 2 to 3 second contraction at the apex. Side planks, 2 sets each side of 10-20 second holds. Utilize knee-supported version if necessary. Cool down 5 minutes. Mild static stretches for hamstrings, hip flexors, chest and lateral torso, diaphragmatic breathing, and relaxation techniques. Development plan spanning 8 to 12 weeks. Weeks 1 to 4. Concentrate on regular practice, refining technique and gradual increments in hold duration or repetitions if feasible. Maintain a low to moderate effort while prioritizing pain-free movement. Weeks 5 to 8. Elevate to 3 sets each exercise. Prolong holds, bridge top holds to 5 seconds, side plank to 30 seconds, or use light resistance band around knees during bridges. Incorporate tempo modifications for squats, specifically a 3 to 4 second descent to enhance eccentric control. Weeks 9 to 12. Introduce unilateral variants, single leg bridge step-ups, or single leg stand tempo modifications, slow eccentrics on squats, and explosive concentric, where safe or extra balance problem standing reaches narrow base squats. Commence the integration of workouts within functional contexts, such as executing rises from various chairs or undertaking lateral stability activities inspired by the side plank while standing. Examples of case vignettes. 1. Mrs. A, 72, diagnosed with early knee osteoarthritis and experiencing challenges in rising from low chairs, initiate with elevated seat chair squats and hand-assisted stands, gradually decreasing seat height over an 8-week period while emphasizing glute activation. Incorporate glute bridges to address hip extensor weakness and perform side planks from the knees to enhance lateral stability. Gradually incorporate pace regulation and partial single-leg stances. After 12 weeks, Mrs. A reports improved transfers, reduced anxiety around standing in public, and heightened confidence in managing stairs. 2. Mr. B, 68. Recuperating from persistent low back pain. Initiate with supine glute bridges focusing on pelvic stability and deep abdominal co-contraction, then advance to marching bridges and single-leg bridges. Implement chair-assisted squats at a deliberate eccentric speed to enhance control while avoiding discomfort. Integrate knee-supported side plank grips to enhance lateral stability while minimizing spinal strain. Throughout a duration of 10 weeks, Mr. B exhibits reduced pain levels, enhanced trunk endurance, and increased stamina for modest gardening activities. 3. Ms. C, 75, exhibiting modest peripheral neuropathy and balance impairments. Prioritize seated to standing exercises with initial hand support, complemented with static balance training at parallel bars or a robust countertop. Utilize knee-supported side planks and seated glute activation exercises to enhance core and hip strength. Gradually eliminate hand support and go to brief single-leg stands and step-ups. Functional enhancements encompass extended ambulation with reduced intervals of rest and a decrease in near-miss balancing incidents. Constraints and the function inside an integrated program. This triangle should be seen as a fundamental element of a comprehensive strategy for healthy aging rather than an isolated remedy. Optimal physical health in older life necessitates frequent cardiovascular activities, e.g., walking, cycling, aquatic exercise to sustain cardiorespiratory fitness with flexibility, mobility exercises, and upper body strength training to maintain comprehensive functional capacity and independence. Cognitive health nutrition, sufficient protein and vitamin D, calcium as necessary. Sleep quality and management of comorbidities interact with exercise to influence overall outcomes. When possible, incorporating multi-domain therapies, such as physical exercise, home hazard mitigation, vision correction, and medication assessment, provides the most effective safeguard against impairment and deterioration. The limitations of evidence encompass variety in study designs, heterogeneity in participant characteristics, and inconsistent definitions of adherence and progression. Responses among individuals differ. Certain elderly folks see swift enhancements, whereas those with intricate multimorbidity may advance at a more gradual pace. The outlined exercises are flexible, but should not substitute for personalized rehabilitation or medical care in the presence of specific pathology, acute injury, or systemic disease. Conclusive viewpoint. Aging is an unavoidable biological phenomenon. Yet the manner and rate of functional deterioration are not fixed. Proactive participation in specific evidence-based exercise enables older persons to maintain strength, balance, and independence. By engaging in consistent practice of 3 fundamental movements, the chair-assisted squat to improve transfer capability, the glute bridge to strengthen the posterior chain, and safeguard the spine and the side plank to ensure lateral stability and avert hazardous lateral falls, individuals can significantly diminish the risk of falls and pain-related disabilities, sustain independence in daily activities, and elevate overall quality of life. With proper guidance, logical advancement, and consideration of individual abilities and health factors, this modest yet strategic allocation of time can produce significant and enduring benefits in well-being and autonomy in later life. Healthcare providers, caregivers, and fitness professionals can assist older persons in implementing and maintaining these habits by delivering explicit guidance, ensuring safe advancements, and employing motivational techniques that honor individual objectives and constraints. This targeted exercise program, when integrated with comprehensive lifestyle strategies such as nutrition, cardiovascular exercise, and social interaction, serves as an effective and potent instrument for promoting healthy aging. Strategies for clinicians and program implementation. Initiate with simplicity and expand. Commence with the most cautious regressions and advance only after proficiency and tolerance are attained. Quantify and acknowledge incremental achievements. Consistently record measurable enhancements. STS durations, repetition totals, hold intervals, and disseminate this information among participants to bolster commitment. Organize sessions based on functionality. Employ real-life events, e.g., rising from a toilet, exiting a vehicle as objectives to contextualize training. Facilitate care coordination. Engage with primary care doctors, pharmacists, and other allied health professionals to mitigate modifiable fall risks, medications, vision home hazards. Establish supportive environments. Provide group classes, community-based sessions, or home visit programs to assist individuals with transportation or mobility challenges. Employ technology judiciously. Telehealth educational videos and remote monitoring can enhance accessibility, but must be accompanied by suitable assessment and safety planning. In summary, committing to a simple structured routine centered on the chair-assisted squat, glute bridge, and side plank can make a profound difference in your strength balance and independence after 60. When performed with proper form and gradual progression, these 3 foundational moves target the exact muscles and stability systems that support daily life, from standing up with ease to walking confidently to preventing dangerous falls. Think of this not just as exercise, but as an investment in your future mobility and quality of life. A few minutes of consistent practice can turn the later decades into a chapter of vitality, confidence, and active living, not just longer years but better ones. If you found this video helpful, please give it a thumbs up, share it with friends or family, and subscribe so you won't miss the next videos in this Healthy Aging series. Stay strong, stay balanced, and keep moving every day. Wishing you good health, renewed energy, and the freedom to enjoy every moment of life starting today. Every day you choose to move, your body responds with strength, balance, and renewed life. Each gentle motion is a gift to yourself, calm, mindful, and full of vitality. Together, we move, we heal, and we thrive. Keep the rhythm of your golden years, nurture health, cherish every movement.